Hello and welcome back to our Shreveport Fire Department May continuing education. This month is going to be over syncope and falls. So let's go over some of the objectives that we want to cover over this presentation, one of which is defining what the difference between the two are, understanding what mechanism-based falls versus pathological falls are, being able to discern between falls and syncope, and then also how to perform a pre-hospital syncopal workup within our wheelhouse, performing a Nexus C-spine clearance, focused trauma assessments, and then also the need for elevated suspicion for special populations and what those are. So what is syncope? It's a temporal loss of consciousness, usually related to insufficient blood flow to the brain. What causes it? Low blood pressure, heart rate problems, heart rhythm problems, standing up too fast, not having enough fluid in the tank, locking your knees too long, vasovagal syncope, which is when you're going to have that passing out, which is the predominant amount of types of syncope that we experience in the pre-hospital setting, pregnancy because of the fluid distribution changes, and hypovolemia or just low volume like we talked about before. So the brain consumes about 20% of the body's oxygen. And without oxygen and glucose, the brain function will stop. A loss of approximately 35% of cerebral blood flow will cause a person to go unconscious. So just think about that. If you don't have enough that's in the tank already, then what's going to happen is that when you stand up or you move really fast or something really frightens you, you're not going to get enough body fluid to the brain, i.e. not enough oxygen, and therefore the brain will shut off. Both the cerebrum and the reticular activating system, the cerebrum being what we think with, and the reticular activating system what turns us awake or asleep, have roles in consciousness and posture. And so therefore, if you have any problems with one or the other, you're going to have problems being able to possibly maintain good posture, you're going to fall out physically, and you may actually have a syncopal episode or a pre-syncopal episode. So what are the classes of syncope? This is going to be kind of a good investment of time for understanding the physiology of what's going on when you pass out. But we have many different kinds. There's reflex, which is going to be our neuromuscular system, our orthostatics, which are going to be our positional changes, cardiac arrhythmias, self-explanatory. If the heart's not pumping correctly, it's not going to move the blood appropriately, and structural and cardiovascular. So let's break this down. 60% of all the patients that complain of a syncopal or pre-syncopal episode are going to have reflex-based. 60%. That means vasovagal, cardiac or carotid sinus syndrome, or situational. They cough, they swallowed, or they have post-urination or post-defecation. Why does this happen? Well, vasovagal in the name is going to be our vascular system, our vessels themselves. If you have a problem with the vessels and the vessels are not adequately transmitting the fluid to the heart, to the lungs, to the kidneys, and to the brain most specifically, then you're going to have a problem where you're going to have a neurally mediated syncope. Because as we mentioned before, if the brain doesn't get the appropriate amount of oxygen, the brain will shut down to protect itself. Carotid sinus syndrome. Sometimes patients have a very overly active hyperreflexive carotid sinus, and your carotid sinuses are going to be at your carotid area in your neck. This is the reason why if a patient, specifically an older patient, if we push down on both of the carotids, there's a good chance that they may actually pass out. This is also the reason why whenever you have a patient that is in AFib, AFlutter, SVT, one of the main reasons or one of the main treatments is to perform a carotid sinus massage. The carotid sinus has baroreceptors in it that then will mediate through the vagal response, and then you will slow the heart rate down. So this then kind of leads into it is that if you vagal down, the heart rate goes down, and the heart rate, the pump, is not able to move the fluid back to the brain. Now let's say, for example, the carotid sinus is hypersensitive. It's going to react if you just put a tie on or turn your neck quickly. Then what happens is that that same therapeutic response that we use for patients that are having tachycardia syndrome are now going to have a carotid sinus syndrome, which is going to cause them to brady or vagal down. Coughing, swallowing, and post-micturition or post-defecation are also very interesting. If you cough, you bear down. Swallow, it can interfere with the baroreceptors on the carotid sinus. And then post-micturition or post-defecation, you're also bearing down as well. When you bear down, remember that is another therapeutic response when you have someone who's an SVT or AFib, A-flutter, in order to try and get them to have a lower heart rate. So if you are now doing that physiologically and you are already hypersensitive, then what happens is that the patient may actually have a reflex vasovagal or a situational response where they will syncopize. Now let's talk about orthostatics. Drug-induced, very common. If you have drugs that lower the heart rate down, lower the heart's ability to pump appropriately, or even just losing volume, and that leads into the volume depletion portion, like with our diuretics or our loop diuretics and our channel blockers down in the kidneys, then what's going to happen is there's not going to be enough fluid in the tank, and so therefore you're not going to have enough fluid to move to the brain. Volume depletion can be done with diarrhea, vomiting, our runners, people who are exposed to the elements very, for a long amount of time, our heat stroke, heat exhaustion patients, they could syncopize just because of the fact they don't have enough volume in the tank. Now, autonomic nervous system failure, primary or secondary, is somewhat interesting. This autonomic failure may be because of a plethora of different reasons. It could be because of cancer that they have or cancer drugs that they're taking to fight their cancer. It can be because of autoimmune diseases, HIV. It can be because of scleroderma. It can be because of lupus. There are many different things that happen, and all this is saying is that these drugs or these infections or these autoimmune reactions target the nerves that are responsible for controlling the normal flow of your heart rate and your blood flow. And so therefore, if you're going to have an autonomic dysfunction where the body's not able to adequately respond to movements in time and space, or even respond to, for example, you have a large meal, your blood's going to shunt into your abdominal cavity to assist with your digestive tract. If you have autonomic dysfunction, then what happens is that blood will shunt like normal, but there won't be any compensatory mechanisms to help the rest of the body. And that's the reason why sometimes if they have a heavy meal, sometimes people can pass out. So needless to say, the autonomic nervous system failure is kind of a special case scenario, one of which is somewhat of a disease of exclusion, where you kind of have to rule everything out before you really think about it. And thankfully, it's only 15% of the total. Now, cardiac arrhythmia is something that we're a little bit more familiar with. People who have 6 sinus or AV block, especially our second, type 1, type 2, and our third degree blocks, and our 6 sinus where they're just beating at 20 or 30 times a minute, the AV node, the Purkinje fibers, and the SA node are kind of all blown out. These patients are really on a downward spiral to illness, and they're going to need to have a pacemaker put in at one point in time before they pass. Now, tachycardia is on the other side of the spectrum. VTach and SVT, VFib is not considered to be a pulse rhythm, and so therefore that's the reason why they don't count that. And if you're in VFib, we're in a different area to begin with. But patients that have spontaneous ventricular tachycardia that just happens out of the blue can occur, and then therefore the heart is not actually able to pump the amount of blood to the brain again, and the patient will pass out. SVT, the same thing. The heart ventricular rhythm is like 190, 200. That's just too fast. It doesn't give enough time for the heart to fill, and the volume's not going to go to the brain. Channelopathies like prolonged QT syndrome and Brugada, what this is saying is that these patients can have a phenomenon where they will go into VTach or SVT if their heart is triggered in an abnormal way. And these patients are at high risk for lethal dysrhythmias as well. So if you find this on the EKG or the 12 lead when you do this, then this is a cause for concern, needs to be brought up to the attention of the physician or the nurse whenever you arrive. It's not just something you just, hey, yeah, I think they're an SVT. You want to be able to identify these channelopathies so that you can be able to communicate that effectively. Now, finally, with structural and cardiovascular, these patients are going to be our patients that, with those structural cardiovascular issues, MIs, aortic stenosis, hypertrophic cardiomyopathy, PE or clots in the lung, pulmonary hypertension where the lungs just do not have the ability to permit gas exchange and the blood exchange appropriately, and then aortic dissection, which all of these, for the most part, are emergencies. And if we're here, then this is really kind of the column that we as pre-hospital providers need to be most concerned about, specifically heart attacks. 12 lead within 5 minutes. Aortic stenosis. If the patient is old and you listen to their chest and they have a blowing murmur, and now this is not something that we do normally in the pre-hospital setting, listening for murmurs, but if you put a stethoscope on their chest to listen to their lungs and you're like, whoa, what is that noise? And they've had a syncopal episode in the hospital setting, that's time for a valve replacement. If they're a young adult, female or male, and they've had a syncopal episode while doing a gym, a sports activity, then that is a high risk for hypertrophic cardiomyopathy and is one of the leading causes of death for our young athletes. So therefore, if they syncopize on the field or in the basketball court or on the soccer field or whatever field that they're on, then that patient does not deserve a refusal. That patient deserves to go to the emergency department for further evaluation. And you must communicate that to the physician and the nurse and say, hey, we were on the field, we got a call, they said that he was doing well, it's not a particularly hot day out, he passed out. That may be a sentinel event of things to come. Pulmonary embolism, tachycardia, and shortness of breath. Shortness of breath is the number one. If the patient's just like tacking away in the low 100s and you're like, that's a little weird, maybe they have a pulmonary embolism. And how do we diagnose pulmonary embolisms? With a CT scan in the emergency department. This patient should not stay home. Pulmonary hypertension is more of a chronic disease. These patients are going to have left heart failure from congestive heart failure. They may have problems from a lifetime of smoking. They may be on some medications that cause their lungs to harden up. Any number of things. That's more of a chronic issue. But leading out all of this is the aortic dissection. That old man or woman that's been smoking their entire life and now they're complaining of abdominal pain radiating to their back with some shortness of breath and chest pain. They may have symptoms of diaphoresis, hypotension, whatnot. And these patients are going to be sick if they're on the other spectrum, and they may not be sick. They may just be presenting to you. So these are the patients that you need to be aware of. So let's talk about reflex-orthostatic syncope. We've talked a little bit about this in the previous slides. Alcohol ingestion, who knew? And this happens by vasodilation, and large amounts of alcohol can cause you to vasodilate, causing you to syncopize. Bowel movements, urination, especially when you're constipated or urinating against an obstruction for those men who have benign prostatic hypertrophy, or even women or men who may have cancer that obstructs their urethra. And so therefore they're bearing down. Well, that act of bearing down will cause their reflexes to occur and their heart rate will slow down. Thereby, if their heart rate is already slow, they may pass out. Stress, heat, standing with the knees locked, and crowds too. Feeling oppressed, that type of agoraphobia-like response can cause you to have a psychogenic effect where then you will then bear down or get in a headspace where your heart rate will go down and thereby you're not actually able to get blood anymore to your brain. So finally, like we mentioned before, carotid sinus stimulation, a tight shirt collar, rapid movements of the head can cause your carotid sinus to be overstimulated and thereby you will have a syncopal episode because of that. So let's take a break real quick and talk about Miss June Smith right here. She's a 52-year-old African-American female. Her chief complaint was she felt dizzy. She's at work. It's not hot in the office. She's got fan blowing on her. She felt really hot and almost passed out at my desk. So, what are some of the questions that you want to ask her? Think about it for a moment. Remember, we're talking about syncope, talking about dizziness, felt really hot. Think to yourself, well, what should I ask my pertinent positives and my pertinent negatives with this patient along with my sample and my OPQRST? So let's talk about her history of present illness real quick. Well, the onset, she was just at her desk, typing, minding her own business, doing her daily duties of work. Does anything provoke or palliate it? No. She was just sitting there. And she's still just holding her head. She just doesn't feel well. She's got a little dizziness. She feels hot. She feels sweaty. Her heart's racing. Does it radiating anywhere? No. What's the severity of her situation? It's moderate. She doesn't feel well. She doesn't feel like she can go back to work right now, that's for sure. And then when did it start? About 15 minutes ago when her coworkers called 911. It's getting a little bit better, and it's never happened before. So, what does it sound like to you? Does it sound like orthostatics? Does it sound like arrhythmia? Does it sound like a structural abnormality? Think about just asking those simple questions. What do you need to do to make sure this patient is not having a life-threatening emergency? Well, continuing on, remember, like I told you before when we started this patient scenario, what is our pertinent positives and what are, our pertinent negatives? So pertinent positives. She recently just got into a divorce with her husband. She had the flu a week ago, and she's had decreased fluid and food intake. Well, man, that sounds pretty, cut and dry there. It sounds like she's got a volume problem, but we still don't know because we haven't done all of the tests yet. Pertinent negatives. She's not having any chest pain, not having any shortness of breath, not having any nausea, vomiting, diarrhea. She hasn't traveled to Spain or China, and she hasn't had any recent medication changes. So that's good, right? I mean, she's not having any belly pain, she's not having any chest pain, shortness of breath. So do I really need to do a 12 lead? Absolutely, you need to do a 12 lead. So what is our preliminary field diagnosis? Based on what we know, June Smith had an acute onset of palpitations, dizziness, lightheadedness, pre-syncopal episode. She says she hasn't been eating or drinking very much for the past several days, had a flu, going through some emotional things. So it sounds like we may have an arrhythmia and we may have a volume problem. So what tests do we need to do? Well, first off, we need to get a good set of vital signs, which we're not going to include in this. This is just a learning episode. But let's just say her vital signs are normal. She's a little tachycardic at the 1-teens, and her blood pressure is like 148/72. So we're not hypovolemic, we're not an SVT, we're not bradycardic, and we're not acutely hypertensive. So those things kind of go out of the window. What else do we do? Always get a blood sugar. Always, always, always get a blood sugar on these patients, making sure that you do not miss hypoglycemia. Now, this patient's having dizziness and lightheadedness, and it's acute onset. What do you think about? Stroke. So we need to do a stroke assessment. We need to just put her hands out, palms up, check for pronator drift, see if she's VAN positive or VAN negative. Ask her for the facial and the asymmetry. Tell her to speak to us. Those are important things to be able to quickly use our sensitive and specific tests for stroke rule-outs. 12 lead. Make sure we don't miss that 12 lead so we don't miss an MI or we don't miss any type of arrhythmic changes. So getting those three things, vital signs, glucose checks, stroke assessment, and then, the four things, and the 12 lead are very important. What's the determination of disposition for Miss Smith? Are we going to say, all right, Miss Smith, you'll be fine. Go and live your life. Call us if you need us. Well, no. She hasn't resolved. She's still in the midst of what's going on. So this is a clear indication that whatever's going on is not over yet, and it is not our place in the pre-hospital setting to say, all right, we'll just go to your primary care doctor. No. This patient deserves to go to the emergency department to rule out life threats. So let's talk about focused trauma assessment. First off, when we go in BSI, scene safe, additional resources, cervical spine, all that stuff, that's great. We do that anyway. That's second nature to us. But more specifically, we need to think about airway, breathing, circulation. So we need to make sure the patient's airway is intact. She's talking to us. Check. Is she breathing fast or slow? She's eupnic. E-U-P-N-I-C or P-N-E-I-C. Eupnic. She's breathing normally. So that means that you need to listen to her heart, listen to her lungs for circulation, and feel her pulse. These are quick, easy, basic skills that be able to rule out many life threats. So we have to make sure that we check the air, we check the breathing, check the circulation, use the stethoscope. We spend money on those Littmans. Let's put them on the chest. Let's listen to the heart and lungs. Make sure that they are breathing appropriately and not just listening from the front, but listening from the back. Because you can miss a lot of breath sounds if you don't listen on the back of the patient, especially in the acute phase of any illness. Feeling the pulses, but not just on one arm, on both arms. You need to feel if they're equal, especially remembering on the previous slide we talked about aortic aneurysm and aortic dissection and all that. If they have unequal pulses on the arms, that is a good sign that there is something nefarious going on, and that needs to be diesel and going to the hospital very quickly. But if you feel the pulse that's normal, it's strong on both sides, or if it's equal on both sides, you're pretty much out of the woods when it comes to the aortic dissection and the aneurysm apart. But you can't rule it out. The only thing that can rule that out, ultrasound and CT. So moving on, our physical assessment. What are the components of that? Head, ear, eye, nose, and throat. Making sure that she didn't fall. She didn't. We asked her if she fell. No, she was sitting in her chair. She's not having any decap BTLS on her head or neck. Making sure her chest by listening, auscultating, okay? And then abdomen, pelvis. Is she having acute midline umbilical pain? Is she having acute right lower quadrant pain for appendicitis? Is she having acute left lower quadrant for diverticulitis, diverticulosis? Is she having an ovarian torsion? These are all things that if the patient was complaining of abdominal pain, well then that could be a reason why she's syncopized, because she's bleeding out in her abdomen. So remembering our differential diagnosis based on what are we actually looking for in our physical exam. If it's positive with pain or in change in inspection or palpation, then we know that something is going on there. Now, they may have chronic pain. She may have uterine cysts. We don't know anything about that. But what we do know is that she's in a crisis right now. And if she's got abdominal pain, epigastric, midline, bilateral lower quadrant, those are pertinent positives on the physical exam that must be communicated effectively to the following change of hands, to the nurse or the doctor. Upper extremity, we already talked about pulses. Now, if she's got a fistula in her arm and it doesn't have a bruit, or she's got this, cellulitic rash going from her shoulder all the way down to her wrist, I mean, now we have reasons to believe she's got sepsis, and it's not just about trauma anymore. So lower extremity, same thing. What happens if the left leg is huge compared to the right? Maybe she's got a DVT about to blow into become a physical or pulmonary embolism. So these are things that looking from head to toe on our focused assessments is very important. Now, you're not like moving the joint, that's not what we're talking about here. Obviously, if there's a trauma, you would do that. But with this in our syncope, and it should be a focused medical assessment, but whatever, you're looking for things that are going to cause this patient to have orthostatic, cardiogenic, or structural change problems that would indicate why the patient's had this issue. Now the back. I mean, not a lot of things can go on the back. If the patient has a positive thump test, she says, I'm having trouble urinating for the past couple of days and it burns when I urinate, and then you feel in her back and exquisitely tender on her right flank, well, now you're starting to worry about maybe a urinary tract infection that's become pyelonephritis. These are things that you need to be aware of, especially if the patient is febrile. Again, that thermometer. We have to use the thermometer. We need to make sure the patient doesn't have, hyperthermia or hypothermia if they're very old, and that corresponds with our physical exam. Our destination disposition. So again, this patient, because they're still in extremis, probably would not qualify for patient refusal, AMA. This patient is saying, if she says, yeah, do you think I need to go? Your answer needs to be absolutely, you need to go. If the patient says, well, I don't think I need to go, you say, absolutely, I think you need to go. And you should say it a couple times, because the patient may still be on the fence. Most of us, we don't want to go to the hospital. We don't want the bill. We don't want to be away from our work, our home, our family, our animals, whatever. And it's just easier to just say, I'll just handle it at home. But God forbid this patient goes home and then we get a call 3 hours later, different shift, different location, and the patient's in cardiac arrest or in further extremis. These are the things that every time that we put our pen to our ESO refusal paper, you need to think about, man, I hope this patient doesn't come back in 4 hours and then it gets called back that this patient had a problem that I may have missed. That is the burden of being a paramedic in the field, is having those lasting thoughts. You can't just be so callous to be like, all right, YOLO, I'm going to do whatever I want to do. It needs to be, well, what happens if something goes awry when they go home? So this patient needs to go to the hospital. End of story. So what about the history and present illness for syncope? Well, details of the prodromes or the facts leading up to the incident, are very important. For Miss Smith, she was sitting at her desk and all of a sudden it came on. Abrupt onset, it's kind of a hot button word. But if Miss Smith was doing a 48K, Ironman, and now in the 36K she says, oh man, I don't feel well. Well, now we have a context of what's going on. Now, what's the duration of unresponsiveness? If they actually did. The difference between pre-syncope and syncope, if they actually did pass out, how long are they out for? Well, if they were out for a couple seconds, well, okay. If they're out for a couple minutes, well, now we have to think, was this a seizure? Did they have a brain tumor? Did they hit their head? And now they have this. So any activity during the period of the unresponsiveness or the altered level of consciousness, were they shaking around, moving all around? Did they urinate on themselves? Did they defecate themselves? Did they bite their cheek, their gum, their tongue? These are all things that you need to be aware of when you start working on your differential, because what can happen? Well, fortunately for us, we don't have that long of a transport time. But what happens if you are in traffic and the patient starts to go unresponsive again? Well, you can put an arm breather on, put a BVM on, try to bag them up while you're waiting to go. Are you going to pull over? What happens if they seize and you are like, man, I wasn't ready for this? You're going to pull out the Ativan or the Versed. You're going to have to give them benzodiazepines. So understanding and anticipating what can happen in your bus is going to be important, because when you're in the back by yourself, that's really when it matters that you need to be able to handle things. And if you can't, then you have to stop what's going on and get your partner a call for additional resources. Now, one more thing, observing the surroundings for temperature, other environmental factors. Do they have a whole bunch of pills around them? You're at a nightclub and you see some mollies on the ground, purple dolphin, yellow mermaid. Okay, well, maybe they are having hyponatremia hypernatremia because now, they sweat out all of their fluid because they're rolling on X. Or they just huffed a whole can of, carpet cleaner over from the gas station, or, all these things. It has to understand, do we have an environmental prodrome, an environmental toxidrome? Do we have a toxidrome from illicit substances or medications? Is it just because, it's hot outside, they were working outside? These are all important factors to understanding why this occurred. Now, simple differentiation between sudden and gradual onset has a very important diagnostic value. If it's gradual, say for example, Mama, she's walking along and she's been feeling like she hasn't been able to quite catch her air for the past couple of weeks, and now she's walking up the stairs with groceries in tow, and she's like, oh man, I almost passed out. Well, it might be a valvular problem. She's old. Now, with Miss Smith, she's sitting at her desk and suddenly, all of a sudden, she starts having this issue. Well, that could be a cardiac arrhythmia. She could have had a spur VTAC or SVT, new onset, because she's falling down or sick or whatever the case may be. So arrhythmic causes are usually going to be sudden in onset, while symptoms of like illness, sepsis, GI bleeding, they may be kind of more insidious and taking a couple days to occur. So if the patient is active immediately prior to the syncopal episode and everything's fine and then it happens, consider obstructive causes. If the patient is recumbent or supine when it happens, consider an arrhythmic cause. Okay? If the patient's standing but they're not really doing much, consider a vasovagal cause. Understanding that positions in time and space also make a huge difference in calculating your disposition and your differential for this patient. Say, for example, this patient was asleep and all of a sudden they woke up with chest pain and they passed out and they woke up again. Well, that would be pretty frightening if that was me, and I'm sure it would be frightening for you. So that needs to go to the emergency department, and they most likely have had a arrhythmic cause or something to that effect. Now, if they're, laying in bed, they get up to go to the bathroom and then they fall down because they've syncopized, well, that might be an orthostatic change. Who knows? They may be on like 100 milligrams of atenolol, which would be very high, but they have a beta blocker that's blunting their cardiac response to orthostatic changes. So understanding how these medications work with our patients is very important. Now, if you get called to a wedding, the patient, had a syncopal episode, they've been standing there and they felt lightheaded, hot, dizzy, and they just passed out. Well, that might be because they locked their knees and they weren't actually able to get the blood supply back from their lower extremities. And in addition, they had a psychogenic cause as well. So context is key. Context is key. Your history is so important. And I know that it's difficult when we get into the doldrums of the day in and day out, but you can make a difference. Your history, just by asking OPQRST, noting the environment, noting what's going on with the patient, if they're swimming in a sea of needles, whatever, these are all things that can really help the health system as a whole. The patient care makes you look great with the doctor and the nurse, because they say, man, this paramedic, this AEMT, this EMT really knows their stuff. They know what's going on, because they did what I would have done anyway. They provided excellent patient care, and that is what we are all capable of on every patient encounter. So let's talk about diagnostics of syncope for a minute. Stroke scale, we mentioned it. Do your VAN positive, VAN negative, knowing what your your visual acuity, and do they have neglect? Do they have any type of aphasia? Understanding when to use that VAN, and also face, testing their strength. You can get done with the stroke scale in less than a minute. It's not hard, and we all know we can do it in less than a minute. We got to do it and record it in the forms in ESO. And the blood glucose monitoring. All right, so what's the worst that can happen? The patient looks like they're passing out, they're hot, sweaty, diaphoretic. You get into the hospital like, yeah, man, I think they're having a stroke. It just happened. Stroke alert, whatever. And then they get into the room, and the first thing they do is get a BGL, and it's 40. Well, that doesn't look very good. Always get a blood glucose monitoring on any altered mental status, any psychiatric patient, and especially any syncope or pre-syncopal patient. It's not going to hurt them. It's just a little finger prick. We're okay. It's worse to come into the emergency department with hypoglycemia that we have uncorrected in the field than it is to let it ride. Okay, we gotta just let it happen. We just gotta do the blood glucose monitorings on these patients. So 12 lead EKGs, very important. If they're having this pre-syncopal episode and they're in SVT, well, we need to start vagal maneuvers. We need to start giving them adenosine. If they're in AFib, then we need to do vagal maneuvers. We need to give them cardizem. What happens if they're in VTAC? Well, oh my gosh, we need to give them amiodarone. There are a lot of things that change the paths of the treatments that we as paramedics and our AEMTs and our EMTs need to understand, that the 12 lead is very important, and it must be done on these patients in order to rule out life-threatening issues, moderate-threatening issues, and not so bad issues. Orthostatic blood pressure, to be honest, there's some really kind of mixed bag opinions about orthostatics. Some people say, all right, hey, orthostatics, they're great and all, but they're not really sensitive or specific. And we use those in the hospital setting. We don't really do a lot of orthostatics. Remember, it's if you go from one position to the other, it's a change of 20 systolic or change of 10 diastolic. So, you need to make sure that if you're doing an orthostatic blood pressure within context, it doesn't hurt to give them fluids. Okay, you can give them a 250 cc bolus of fluids if you really think they're hypovolemic, and see how they're doing. Obviously, if we were in a rural area and we had a 30-minute transport time, well, yeah, we might have a little different opinion about what we can do with and without fluids. But orthostatic blood pressures, when done appropriately, require 15 minutes of time, 5 minutes between each time, and a rest period in before. Well, we don't really have that time, especially when operations is asking you, hey, you need to get off the scene and go to the hospital if you need to go. Get your disposition. Well, we don't have enough time to do 10, 15 minutes of orthostatics, not to mention everything else we're doing, because you're not supposed to be messing with these patients. During that time, you're supposed to just let them rest so that you can get a good evaluation. Well, that's a hospital thing. We can let the patient rest and get a good evaluation. So just making sure that if you're concerned about orthostatics, that you look at the picture of the patient holistically with your physical exam, your vital signs, and maybe you can do from like laying to standing and seeing how that goes, so that you can say, oh yeah, we did have a positive orthostatics based from laying to standing. We gave them enough time to rest in between, and so this sounds like it may be a hypovolemic or an orthostasis issue. That's cool, that's appropriate. So what are the emergencies of syncope? Well, we already talked about them. Stroke, usually not self-limiting. Altered mental status, neurological deficits. You're going to use that stroke scale, the VAN and the FAST, or whatever skill you want to do, as long as you record it in your narrative. You're going to do a glucose check. Absolutely. Always do a glucose check, which leads me into hypoglycemia. It will not fix itself. Patients will not improve mental status without your administration of glucose. If they can't swallow, you give it IV. If they can't swallow, give them an PO. And PO is actually very important because PO is a good way, because that is the body's natural way to absorb glucose. So let's talk about seizures. Patients may experience an aura prior to the event, may exhibit focal or tonic-clonic seizure activity. Patients may recover gradually from a seizure. So, obviously if it goes unattended, just a breakthrough, the patients may just do better. Now, trauma, on the other hand, that's a mixed bag. What's injured? You need to perform a cervical spine check for all falls and syncope. If they say, well, if they're just at their desk and they didn't fall, no one's seen them fall, well, then that's okay. But if you see the patient on the ground, the first question you need to ask is, did they fall? Or did you bring them down to the ground for their safety? Because, crazier things have happened. Cervical spine fractures do occur. So we need to do our due diligence and do a cervical spine clearance and document an ESO with an intervention in the form, or pop an SMR collar on them, and so just be done with it. So let's talk about fall for a minute. Falls are very common, as we know. Patients 60 years or older, 11.5% of all EMS calls in 2021 were related to falls. 12% almost. That's a lot. Fall calls increased by over 260% over the past 10 years. Well, why does that happen? Our aging population. Make sure to ask how the fall occurred and what was the context of the fall. So, for example, Papa was at the nursing home. He said, I wasn't wearing my socks. I wasn't wearing my shoes. I slipped and tripped. Okay, why did you slip and trip? Well, I just slipped and tripped. I caught my foot. Okay, well, are you sure you weren't dizzy, lightheaded, didn't pass out? No. Okay, so how many times have you fallen? Oh, this is the first time. Cool. Now let's change the script. Yeah, Mama, middle of the night, she had to go pee. She slipped on her feet and fell. Okay, she's not having any dizziness, lightheadedness, or syncope. Okay. Well, how many times have you fallen? Oh, I've been falling a lot lately, like maybe 10, 12 times in the past week. Okay, well, that's not a mechanical fall anymore. There's something else going on. And eventually, Mama is going to slip and trip, hit her head, and then have a brain bleed and die at home. So we need to make sure that we are evaluating these falls for mechanical versus pathological falls. So, for example, with our pathological fall is the antithesis of a mechanical fall, and what it is I passed out. I had a seizure. And, I fainted. I've been falling a lot. I feel very weak every time I get up. I can't move. I can't walk. I fall. I crawl out of bed to crawl to the bathroom, So these patients must come into the hospital. A mechanical fall can just be a lift assist as long as you document that you've evaluated their spine and you've got one set of vital signs. This is very important because you need to have a snapshot in time. If Papa fell, did not tell you that he hit his head and then dies in his sleep, and then now all of a sudden the family comes back justifiably and say, well, why didn't you transport him to the hospital? The only thing that will save you is your documentation. We did a cervical spine clearance on the patient. The patient was alert and oriented. The patient denied any head trauma. The patient denied any bodily pain. The patient reported that he was just walking, tripped on his foot, and then caught himself before he fell. He was alert and oriented, 4 out of 4. Risk of refusal was documented and verbalized by the patient and the crew. All of signatures were witnessed, and so on and so forth. Because these are a chance for liability, and liability is dangerous for the institution or the department that we're in, and it's also dangerous for your license as well. So you need to make sure that when you're doing these lift assists, when you're doing these falls, that you are purely categorizing between mechanical and pathological, and understanding that these patients, some may be born or dying, but others may be kind of those like diamond in the sand. If you don't ask, well, how many times you've been falling, then they would never volunteer to you. Maybe they don't want to lose their independence. They want to stay at home. And now all of a sudden, you ask, how many times have you fallen, Miss Smith? Oh, 10 times. Oh my gosh, Miss Smith, that's dangerous. We need to bring you into the hospital. There may be something wrong going on with you. Oh, okay, if you insist, or better yet, I'm not going to the hospital. There's nothing wrong with me. Well, quote unquote, patient said there's nothing wrong with me and put it into the chart. because that is what protects you, your family, your livelihood, and the department. So let's talk about spinal motion, cervical spinal clearance, okay? So the nexus is the mnemonic. It's neurological, ethanol, extreme distracting injury, unable to provide history, or spinal tenderness. What is a distracting injury? Any painful injury elsewhere that could distract the patient from recognizing the pain associated with a neck injury. For example, you got into a car accident. The patient's complaining that they were wearing the seatbelt and their clavicle hurts and their pelvis hurts and their belly hurts. Those could be considered distracting injuries. You may not be able to clearly ascertain, does this patient have a cervical spine injury? So when you go down this, do they have any focal neurological deficits? Squeeze my hands, move your feet, so on and so forth. Have you been drinking? Are you taking any substances? Now, at one of the other departments that I was with before, they stated, well, what happens if the patient has some dementia? That's a very good question. What happens if they have dementia? Well, if they are unable to provide a history and they're kind of like out of it, then you cannot cervically spine clear this patient. So if they had been drinking, well, everyone says I've only had one beer. Well, if you have a high index of suspicion with you can smell an odor of alcohol in the air, beer cans littered on the ground, and the car that's been, rolled over, these patients do not need to be cervically spine cleared. Any distracting injury we talked about, and then spinal tenderness, midline flexion or deformity. So if you're pushing down the midline spine and they say, ow, positive. If you tell them, okay, well, put your chin to your chest, ow, where does it hurt? Oh, right in the middle, positive. Look to your left, look to your right, ow, where does it hurt? Midline, positive. Now, if they can't say, when you push on their back of their neck and you're feeling on both sides of their neck and they say, oh man, it all hurts, positive. Okay? So you cannot clear those patients. All right, just pop a collar on them. And you remember, we all remember what it was like back in the day when everyone had to be, strapped to the backboard, cervical spine collar, head blocks, all of that. So, we can get away with a cervical spine collar now and then just putting them on a scoop or putting them onto the stretcher. So standing takedowns of ambulatory patients should not be performed. Extended transport times greater than an hour should not be placed on a long spine board because of the fact that all it takes is for 45 minutes to an hour for mama or pawpaw to develop pressure ulcers. Spinal motion restriction will also always be documented. It needs to be documented in your flow chart in ESO. It needs to be documented in your narrative. So when do we really decide about when do I use the scoop stretcher versus a spine board? Well, to be honest, the cervical collar and stretcher is pretty much the go-to, all right? Now, if they do require a board, pop the cervical collar and the scoop on because the patient can be taken off of the scoop and we can, retain our equipment. It's better for the patient. A long spine board should really only be used at times of, extrication from a vehicle for our extended extrication, or if you're taking someone from a, high angle rescue in the water, things like that, that you're going to have to require a little bit more substance than a scoop stretcher. So making sure that you also anticipate scenarios that a long spine board is needed, like we said before, the extrication kind of a situation. So if you're in a car, consider using the Kevlar extrication device, the KED. It's easy to take the patient out, and you can take that patient with the KED, and you can do log rolls to get them off of it. But, it's an easy extrication thing, and you're not shoving that longboard underneath their pelvis, and God forbid they have a pelvic fracture. You're not making that worse. So just keep those in mind. When you go on scene, that BSI scene safe, scene disposition, that third one, what are you thinking about? What do you need? What additional resources do I require? One of those resources is, do I need a scoop? Do I need a KED? Do I need my longboard? Do I need additional resources because this patient, you see, the car is upside down and for some reason the A and B posts are welded shut magically. You're going to have to be with that patient for a minute. You're going to be with them for a while. So just understanding those additional resources are very important. So patient 2, Jack Snyder, he's 71. This is how you find him. Poor Jack. He's on his belly. He says, I was walking on my carpet and I felt off. Then my right knee gave out on me and I fell. And I've just been laying here on my shag. So, let's talk about the history of presentation. You get Jack up, you spinal clear him, he's fine, he's happy. He's not, breathing in the shag carpet anymore. He says he was walking on the carpet, nothing made it worse or better, he just felt off. He felt sick to his stomach when you ask him what it meant. He's not having any radiation or regional issues. Severity is mild. He says he feels better now. He says 10 minutes ago, still with some mild stomach pain, but it's new. Everything's new, So think about what you need to ask for pertinent positive, pertinent negatives. Jack, he's a little older. I'm sure maybe he's had a heart attack, or maybe he's on Plavix or aspirin, Maybe he's just had some bad tacos. Who knows? So let's talk about the pertinent positives. So recently he had an endoscopy for stomach ulcers that was negative. Oh no. Why did he have this endoscopy? Well, he's had epigastric pain for a while. He's been eating and drinking okay though. All right. So pertinent negatives, he's not having any chest pain, shortness of breath, vomiting, diarrhea. Recent international travel, he hasn't gone to Belize. No medication changes. He's not on any thinners. And then one important thing that I didn't mention on here is, are you vomiting blood? Are you urinating blood? Are you defecating blood? Very important. We already thought that he had stomach ulcers. Maybe he passed out or maybe he fell because he got a little weak. Remember he said he fell off. So what's our preliminary field diagnosis of Mr. Snyder? Is it a mechanical fall? Is it a pathological fall? Well, going back to what we talked about on the previous slide, when we talked about our mechanical falls, it was a slipped and tripped, no LOC, no altered mental status. He has a history of chronic epigastric abdominal pain that's being actively worked up by his doctor. So maybe it was just a mechanical fall. What tests do you need to do? Well, we certainly need to do a physical exam to rule out any other, breaks or anything like that. He looks a little older. If he's not having any chest pain or shortness of breath, document it appropriately. Get a good set of vital signs. I would get 2, right when you get there and right before you leave, if this is a refusal kind of a thing. What's the determination for disposition? Does this patient need to go to the hospital? Well, Mr. Snyder, do you feel like you need to go to the hospital? No, I'm okay. Okay, well, you fell, talk to him about wearing appropriate shoes. He says knee gave out on him, work the knee a little bit, see if it's, he broke it. He didn't. Does he need to go to his primary care doctor and get that taken care of? These are all things that you can facilitate as a paramedic to say, yeah, you need to go to your doctor to look at your knee, sir. It may be going out on you. Like you said, you fell because the knee gave out. So I think Mr. Snyder probably be okay living at home. So again, our focused trauma assessment, what do we start with? Airway, breathing, circulation. Listen, look, feel, everything's good. His vital signs are stable. Talking about our physical exam, head, ear, eyes, nose, and throat, chest, abdomen, pelvis, feeling that rock if he has any. Upper extremities, everything's good. Lower extremities, like I said, work that knee and then check his back to make sure he doesn't have any pain on his spine. Destination, disposition, we talked about. Well, I think Mr. Snyder probably will live just fine at home. So finally, let's wrap up our journey through time and space here with our special populations. Any pregnant woman that falls on their abdomen needs to have cardiac tachometry in the hospital, in the emergency department. This is very important. They may have placenta previa or abruptio placenta, where they may have painless vaginal bleeding. They could have painful vaginal bleeding. These are all things that need to be managed in the emergency department. Pregnant women need to go to the emergency department if they've fallen. Even if it's like, oh, I tripped and I landed on my knee, okay, that's different. But if I tripped and I landed on my belly, okay, all right, time to go to the hospital. Geriatrics, they're frail. They may have osteoporosis, you don't know. They may be on polypharmacy, like we talked about the next one. But geriatrics, you need to have a higher level of suspicion about what started the fall and what's causing the fall to persist. So they may need to go to the hospital more than the less than 65 crowd. Polypharmacy, if your patient's on 50 medications and you only recognize 4 of them, hey, that's a problem. They need to, if it's just one fall, okay, but they're having multiple falls and they've had recent medication changes, it might be time to go to the emergency department so that the emergency doctor can evaluate their medication list and evaluate them for any type of like precipitating reasons why they're having these falls. The final one is recent hospitalization. All right, if they've been hospitalized within the past 15 to 30 days, this is also a higher risk population. We don't know if they have an infection from the hospital, if they're having some consequences of medications that were put on. So again, these patients need to have a higher index of suspicion of something else is going on with them. So let's watch a video real quick. This is kind of an uplifter video. It's very short, but it was from our partners over in Canada about a fall and why paramedics are needed. All right, so let's watch our video from our partners in Canada. It's titled "A World Without Paramedics," and it's about a fall and how much we do make a difference on an everyday basis. So very important aspects here. Obviously, the patient fell from a 2-story structure, landed, had to have a needle decompression, spinal immobilization, intubation, and they really did make a difference because, as you can see, the alternative version is that, the sons just threw him into the car like a sack of potatoes, and Lord knows what fractures this man sustained. Obviously, at the end credits here, we see the patient was in a wheelchair. So we do important things every single day, and we do the right things every time. Mistakes are limited and outcomes are improved. And thank you so much for joining me for this month's Syncope versus Falls Continuing Education. If you have any questions, I welcome them. Thank you.